Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting this call today. This afternoon, we're talking about the fiscal year 2026 ICD-10 coding updates of note for home health and hospice. And now I'd like to introduce our industry guests for this episode. Today, we have OC Advisory Board member Lisa Selman-Holman with us, and we have OC Advisory Board Chair Sherri Parson with us. Thanks so much for joining us today, Lisa and Sherri.
Well, thanks for having us.
All right, let's get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane and we'll try to get to as many as we can. Lisa and Sherri, I'm going to turn things over to you. I know you have a lot to share today. Just let me know when you'd like me to advance each slide and we'll keep things rolling.
All right, thank you. So first we're going to talk about the code transition. And the official statement from CMS I have on the slide, these 2026 ICD-10 codes are to be used for discharges. Now I want to say that part does not apply to us. We're not using it for just discharges occurring from October 1st through September 30th. That wouldn't make sense for home health. But part that makes sense for us are to be used for patient encounters occurring from October 1st through September 30th, 2026. So these codes go into effect for encounters beginning October 1st. And that means any visit occurring on or after October 1st must reflect updated codes on the claim. Next slide. So what does this mean for billing? Billing periods that begin September 1st and end October 1st, that means that may span both code sets. And so you have to consider whether you have to change any of the codes on that particular claim. And of course, that moves forward. If any visit, which is considered a line item, occurs on or after October 1st, you have had an encounter October 1st or later, and the entire claim must reflect those new codes. Claims submitted with outdated codes for visits on or after October 1st will be rejected or RTP, returned to provider, or fixing. So agencies really have two options. They can update the codes before submitting the claim, or they can wait for the claim to reject, correct, and resubmit with updated codes. So some agencies choose the latter. Some agencies are more proactive in updating those claims before they're sent in the first time. So what about hospice? Again, if any date of service on a hospice claim falls on or after October 1st, the entire claim must use updated diagnosis codes. If the claim includes only dates of service prior to October 1, the current pre-October 1 codes remain valid. And then again, the claims that include outdated codes for dates of service on or after October 1st will be rejected and must be corrected and resubmitted. Next slide. On to you.
Okay, thank you. So we have some new codes for inflammatory breast carcinoma. This code was presented by the Susan Komen Foundation, and the purpose was to more accurately distinguish this type of breast cancer. Their idea was this would promote more accurate and more frequent diagnosis of IBC. Now, this is a rare type of breast cancer, and usually by the time somebody is there to get diagnosed, they've got symptoms, it has metastasized to other areas of the body. Unfortunately, it's pretty aggressive. And sometimes even on the initial presentation, the provider is missing it because there's no palpable lump, there's just some inflammation of the tissue, and sometimes it even gets missed initially by the provider. Next slide, please, Jan. So how are we going to get to these codes in the manual? You'll see over there on the right of the screen there, the alpha index. We're going to go to inflammation, inflammatory, breast, down to cancer, and it's going to refer you to that table of neoplasm. Now you can see the table of neoplasm down there. When you get to the neoplasm table, you're not going to stop at breast. If you stop at breast, you're going to have the wrong code. You're going to look for that new term that's in there, the inflammatory, and that is going to take you to the correct code, that's C50A. And then you're going to have 3 selections there. You have the A0 for unspecified. Hopefully we don't have to use that. A1 for the right breast, A2 for the left breast. When you switch to the tabular, you're going to find this at the end of that C50 section in the tabular. Next slide, please. Now, even if you're not following all the changes for October 1st, which I hope you all are, you have probably heard about this one. This is a pretty big addition here. For years, we've had our bariatric surgery patients had the Roux-en-Y, and it seemed like the diabetes was cured. Then we had the GLP-1s and massive weight loss, and all of a sudden, you know, we're seeing these normal blood sugars. But clinically, we've always been told once you have diabetes, you always have diabetes. So this was a welcomed code addition for this remission. But what we have to kind of keep in mind is there's a couple caveats with this. The first is to assign this code. Clinically, the presentation is that they have normal blood sugars for at least 3 months, but we can't just code on that lab work being those normal blood sugars. We actually need that provider statement that the patient has remission, diabetes in remission. So when we see other terms like resolved, cured, that's not going to cut it. Those aren't synonymous with remission. We actually need it to say remission. So what happens if we've got our patient, we have the normal blood sugars, the provider actually tells us that they have got diabetes in remission, but let's say they have a manifestation such as diabetic neuropathy. You see right there in the code title, we can't use this when there's complications. So if we had somebody that presented with a complication already, we're going to continue to code that diabetic polyneuropathy. For example, we cannot assign that remission code. Even if the doctor tells us that it's in remission, we have to go back and code that complication. Next slide, please. And this is just a reminder that we do not have synonymous terms. If there is some other terms, cured, resolved, we think the provider is talking about remission, we're going to need to query that physician or that provider to get that documentation before we can assign this code. And I'm going to send it back to Lisa.
Okay, so this is from the Coding Clinic, Q1 2025, and we still get lots of questions about this. So bottom line, venous insufficiency is not considered a diabetic peripheral angiopathy. There were Coding Clinic letters that went back and forth, and some people changed their practice based on the first Coding Clinic letter, and then there was a second Coding Clinic letter, and I was trying to get people to change their practice, and I was actually told, no, we're not going to follow letters. And I had to say, well, you're following a letter if you're doing it now, because that was a letter. But now we actually have it in the Coding Clinic. Venous insufficiency is not considered a diabetic peripheral angiopathy. So a patient has type 2 diabetes, history of venous insufficiency and venous stasis dermatitis, admitted with a venous ulcer to left shin with exposed fat layer. How should this be coded? We're going to code the venous insufficiency. We're going to code the ulcer. And by the way, that's with the calf, because shin is now calf. E11.9, type 2 diabetes without complications. And there's a rationale there for you on the slide as well. And then there was a new guideline in April 2025 that is still confusing a few folks. So we have kind of a change in what they said, and they did say it in Coding Clinic first quarter 2025. So they tried to clarify what they messed up before, and then they add the guideline. So sometimes the physician or provider may document both morbid obesity and class 3 obesity, and the winner when that happens is class 3 obesity, E66.813. So you don't code both morbid and class 3. The unfortunate piece is morbid obesity is one of those comorbidities that gives you a little bit an extra bump in payment, but they did not add class 3 to that list. So we're going to need to talk to them about that. Next slide. And then hypercholesterolemia. This is probably something that you won't see very often, but there is a familial hypercholesterolemia, which is a rare genetic form of high cholesterol. And so there are new codes that they added for homozygous, which would be one gene affected, and heterozygous, both genes affected. And then you have an unspecified code, E11.A Of course, all those are found under hypercholesterolemia, and they're actually under the regular code that would normally use, the E11.A code that would normally use. And that's where it is.
Okay, so we have more specificity in MS that's been added. The additions of specific codes for the phenotypes, I believe, is strongly related to the pharmacy world. Treatments and payer coverages are usually closely aligned with specific phenotypes. Relapsing, remitting, multiple sclerosis is the most common type there. That's up at the top. We refer to that as RRMS. And what you will see, these are your patients that come in and out of home care. You know, we're cathing them, we're getting steroids. We don't see them for a while. They have a relapse, they come back. But we also have this primary progressive multiple sclerosis here. This is the only type of MS that we will see payers paying monoclonal antibodies for. So Ocrevus, a monoclonal antibody, is the only treatment for this, and it's only FDA approved for this particular phenotype. So again, when we're looking at these specific phenotypes, they're directly related to what we can use treatment-wise from the FDA for a particular type of pheno with the MS. So then the secondary progressive, this is where you're going to see your immune globulins, your biologics, those biosimilars, they're all used for this particular type. But what you're not going to really find is that any of the criteria in the medical policies are related to the unspecified. Now, of course, before we had these phenotypes, October 1st, we kind of grouped them all in there. So just kind of a note to those of you that have infusion pharmacies with your home health, those drug authorizations are usually good for a year, but just keep in mind that when those come back, you're not going to want to slap that unspecified code on. You're going to want to make sure that for the authorization, you have the specific phenotype so you can get the specific treatment covered. So again, that is going to be kind of a big one for those of you in that pharmacy world. Next slide, please. So muscular dystrophy has many major types and subtypes also, and of those, that limb-girdle muscular dystrophy, they were particularly concerned about the 2I and the R9 subtype. So before we had this code, the G71.038, and all the inclusion terms were under there to capture all of those. We have this new code added this year, the G71.036, and again, that's to capture that 2I and that R9 and the synonyms for that. So those inclusion terms were all moved up there, and now if you look at the box there on the right, those are now the only two that are going to be listed under that G71.038. Now keep in mind, that is a valid code, right? It was a valid code, it is a valid code. However, you may have the wrong code, right? So if you do have that 2I or that R9 type, you really need to change that code to that G71.036. The claim isn't going to kick out for a non-valid code. However, you're going to have the wrong code. All right, and I'm going to send this back over to Lisa.
Okay, we have a huge change to hypertension.
Yes.
I think it's huge anyway.
I think so too.
It's one of those that people have not had a good understanding of it to begin with, as far as the includes that you see at I11, and then I13 includes anything in I11 and I12, and it makes a great test question and all those kinds of things. But they've decided some of these I51 codes should be coded as an extra code when you have hypertensive heart disease, whereas they've all been included before. So at I51.5, myocardial degeneration, they have added excludes 1. So you cannot code I51.5 along with I11 or I13. See, that excludes 1 there. Same thing with I51.7, cardiomegaly. You cannot code I51.7 along with an I11, I13. They moved the exclude 1 note under I51 that said all of these can't be coded with I11, I13 to just those 2. So what does that mean? Next slide. And that's a one-way excludes note, by the way, if you're wondering why I have that sign over there. Okay, So what the bottom line is use an additional code to identify myocarditis, other ill-defined heart disease, and heart disease unspecified. And that doesn't make logical sense to me, but you are going to add the code for myocarditis, I-51.89, other ill-defined heart diseases, which include your diastolic dysfunction, systolic dysfunction, where they don't mention heart failure, and I-51.9 heart disease unspecified. So you're going to add the codes there, but you're not going to add the codes if it's hypertension with heart conditions classified to I-51.5, myocardial degeneration, or I-51.7, cardiomegaly. So to me, that is backwards in my head. So I have to just remember 57 doesn't get coded. So I-51.5, I-51.7, 57 does not get coded extra. The other ones do. And just remember, not new, but still important, that the include note at I-13 specifies that the conditions included I-11 and I-12 are included together in I-13. So this also applies when that patient has hypertension with chronic kidney disease plus end-stage heart disease, for example. Now you're going to add the I-51.9, whereas right now you would not. Next slide. So just a little visual for you. If you have hypertension with cardiomegaly, if you have hypertension with myocardial degeneration, you're just coding I-11.9. But if you have hypertension with myocarditis, hypertension with diastolic dysfunction, hypertension with end-stage heart disease, those are examples of things that would be included in those codes. You're going to add the other I-51 codes, I-51.4, I-51.89, and I-51.9. So again, it's backwards to me because they've been telling us for years when you have a condition that's included in the first code, so I-11 would be hypertensive heart disease without heart failure, and the second code does not provide any additional information, there's no need to add it. And here we're doing it, we're adding it. So again, backwards in my head. So just remember 57 doesn't get coded, the other ones do.
All right, we have a whole lot of non-pressure chronic wound codes, and you are going to see we've got different anatomical locations here. This is a beautiful slide. I can't take credit for it, but a really nice way to condense a lot of information. So I love this slide. Again, I'm not the author of it. You've got your anatomical locations on either side. On the right here, what you're going to notice is these are going to end up being 7-digit codes. So you've got a laterality piece there. So you've got your location, you're going to have your laterality digit, and then you're going to have your digit out of the blue box there for severity. When you're looking over here on the left, you're going to have your location, but you're just going to have another digit there, the blue boxes for the severity. So obviously with all the different combinations that you can have for laterality, location, and severity, you can see why I'm talking. There's a whole lot of these codes here. And then next slide, please. So this is really the reason for all of these, wound codes that we have here. So really what has happened is that it's a way to capture specifically what's going on with this toxic illicit drug. Xylene is actually used in veterinary circles. However, it's not, approved for humans. And it has been added to a lot of these illicit drugs. So fentanyl, heroin, cocaine. What happens is it's a vasoconstrictor. So when you inject this, not only could you have wounds and necrosis and things at those injection sites, but really anywhere on the skin because of the vasoconstrictive nature of these. These are very, very nasty wounds. And really what kind of prompted this getting added is that a lot of the peer-to-peer literature was capturing these codes as just full thickness wounds, which is true often, but you don't have that underlying etiology that you're actually addressing there. And without that underlying etiology, you're going to have a hard time making any headway with these wounds. So kind of a big deal there. Lisa, anything you want to add to this? I think you've seen some of these pictures. Yeah.
they were calling them full thickness wounds, and of course people were coding them as open wounds, which would mean trauma, but it wasn't trauma. And then the zombie picture is because that's what they're calling these, is zombie ulcers. And I try to just put a piece of an ulcer there, because if you are prone to Google things, those wounds are horrible wounds. Just
Yes.
awful, just awful.
Yes, absolutely. Next slide, please. So we were a little happy. We said, oh, they cleaned up some stuff. J44, exclude 1 notes, changed to exclude 2 notes. But then we discovered that J42, we have the same exclude notes. Anything you want to add to that, Lisa? It poses some dilemmas.
Yeah, it does. So J42 has an excludes 1 for J44, and J44 has an excludes 2 for J42. So opposite. And it really doesn't make sense that they changed that to an excludes 2, because when would we code chronic bronchitis unspecified along with chronic obstructive bronchitis? It makes sense with chronic simple and mucopurulent bronchitis and COPD, even maybe chronic tracheitis could make sense, but there's something wrong there.
Yes.
And I'm not sure what it is. I don't know if they decided to make the change and then didn't follow through with the whole thing, or they changed their mind and then forgot to take it out. So yeah, we'll follow up with that one.
Yes, for sure. Next slide, please. And this is Lisa.
Okay, flank is added as a new anatomic site. So there was a lot of discussion about the abdomen really wasn't right, and the back wasn't right, and so they actually added flank. And so you see a lot of flank for punctures and abrasions and even insect bites, every type of wound you could have, every type of condition you could have that would affect the flank. There it is. There's flank pain slides, contusions on the flank. One slide that I didn't add is the fallopian tube was added as a site in a lot of places. And I thought, I wonder why. But then I saw an ad for the Johnson baby powder class action, where all these people are getting cancer of the fallopian tubes, and I thought, aha, that's why they added fallopian tube as a site. We have lots of choices here. Back to you for the Cipro. Oh, this is mine too, huh? Okay.
Yeah.
So they made a mistake. I can't remember whether it was last year or year before, where they had pelvis as a special code, but then they had pieces of the pelvis like the ilium and the ischium and the pubis in the wrong code. So they fixed that this year. So that's good. All of pelvis and any piece of the pelvis is all in the right code now. We did find a typo in the alphabetical index, so you see a little red box around that one. So they mistakenly put M80.8B, and that should be not 8, it should be 0B, because 8 is that secondary osteoporosis.
Okay, so here I am. Fluoroquinolones, we know these as those anti-infectants, Cipro, Levaquin, some pretty big hitters there. I remember years ago, maybe a few years back, there was this anthrax scare and everybody was grabbing up the Cipro, and then you were getting all these reports of muscle tendon rupture and all of these adverse side effects to the Cipro. And what the FDA is feeling is that these types of adverse effects to these fluoroquinones are really not getting captured. So they wanted a code. They felt if they had a specific code for these adverse effects, that we might track those better and we might be able to see what's going on with our Cipros, our Levaquin, and so forth. So that is one reason that this was added. And so more to come on that, because I'm sure it's going to provide us with a lot of data. Next slide, please. All right, genetics accessibility, and Lisa kind of touched on this a little bit. This slide does not include either the removal of the fallopian tube prophylactically, the Z40.031. What we have seen for years is ovarian cancer is actually starting in the ends of the fallopian tubes. So to prevent ovarian cancer in individuals that have genetic predisposition for that, what they were doing to treat this was removing the fallopian tubes and the ovaries, because again, that ovarian cancer actually starts in the ends of those fallopian tubes. So we're seeing with people that get, multiple sites of cancer, that they're encouraged to have genetic testing so that, again, their family members can then be proactive in their care. So I know my husband had several primary sites. They did do some genetic testing on him, found that he had a defect. So then the kids were tested, of course, to make sure that they didn't have any of these, including ovarian or breast was a couple of them that would have translated to this particular mutation. My kids did not have it, thankfully, but if they had, then that would actually allow the payers to pay for things ahead of time, mammograms that are, earlier than we normally do, or removal of, fallopian tubes and ovaries that they would cover because of this genetic susceptibility. So very important code additions, fascinating area of study where they're doing all this genetic mapping. And next slide, please. All right, I think Lisa, you're gonna maybe review this, huh?
Okay.
All right. Okay, so thanks again for all of that.
Oh, thank you.
Lisa and Sherri. Yeah, yes. And now, yes, we're on to scenario spotlight. And Lisa, do you want to run through this one?
Sure. A 78-year-old male patient received home health services for a recent stroke and right-sided weakness, begins experiencing a new onset of chest pain. He's transferred to the emergency department at 10 p.m. on June 12th, receives nitroglycerin sublingual that relieves the chest pain after 2 doses. He also has a cardiac workup, and after consult with cardiology, he is admitted for a diagnostic cardiac cath scheduled for 4 p.m. on June 13th. The cardiac cath reveals no acute blockages, and after spending the night in the hospital, he's discharged at 10 a.m. on June 14th to resume home health services with a new prescription for nitroglycerin and a follow-up appointment with cardiology in 1 week. So which of the following is the best option? This is an OASIS question, so I would say there's 2 parts of OASIS. One is how to answer the items correctly, and even though this is technically an item, the other part is knowing which thing you're supposed to fill out with which date. So, should we complete a 6 transfer not discharged with MU 906 date 6/12 and MU 103 resumption of care by 6/16? Should we complete a 6 transfer not discharged with MU 906 date 6/13 and MU 103 by 6/16? And then C is complete MU 105 other follow-up when the patient returns home. Or D, no OASIS assessments are needed. So essentially, was the patient admitted? Was it for other than diagnostic reasons? Was it greater than 24 hours? That's what we're looking at. So let's look at the
answer. Yes, here's our answer.
The correct answer is 5 other follow-up. And of course, you don't have to complete the 5 other follow-up. It's according to your policy. But there are no other OASIS assessments that are required because the cardiac catheterization was a diagnostic test. Patient had a significant change in condition, though, that requires a reassessment and change to the care plan, again, according to your policy. But a 5 would be the correct OASIS if you're going to complete any OASIS at all. And you can find that in category 4, question 23.6, question 23.10, and question 23.10.1.
Thanks so much, Lisa. And we have another scenario up for you to consider this month. Our September scenario looks at a patient who is admitted to home care with diagnoses of new onset paroxysmal atrial fibrillation, hypertensive chronic kidney disease, diabetes in remission, peripheral neuropathy, CKD, and a history of a CVA without residuals. And we are looking for the best coding choices for this patient. That scenario is in your handouts for this call. So take a look at that, think about how you would code it, and we'll share the answers on the next episode. And if you're listening to a podcast version of this show, you'll find the handouts on the AHC website along with the recording under resources, free webinars. We would like to take a moment to thank our sponsor for this month's program, Decision Health's Home Health Pro. Decision Health's Home Health Pro is your all-in-one education hub built for both new and experienced coding and OASIS reviewers. Get a real-world training using actual medical records to boost accuracy, stay compliant, and ensure ethical reimbursement. Stay current with code updates, regulation changes, and more. You can learn more at the link in your handout. And now it's time for What's New with AHC, where we share updates from the Association of Home Care Coding and Compliance. And we would like to announce the AHC Advisory Board officers for the 2025-2026 term. And as I mentioned at the top of the show, our new chair is Sherri Parson. And our new vice chair is April Swafford, and the secretary is Christine Mickle. And I'm sure all of these folks will be joining us on future AHC Talk calls. So we're looking forward to working with all of them this year. And I also want to invite AHC members to take our AHC member survey. It's live now, and the link is in your handouts as well. Please take a few moments to complete the AHC member survey to let us know how we're doing and what more we can do to help you in your work. We hope you enjoyed this episode of AHC Talk. Thanks again, Lisa and Sherri, for all the great information. That was a great rundown. And thanks to all of you for tuning in. Please join us again for our October call on the 23rd, when we'll be talking about skilled services and medical necessity. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find AHC Talk on your favorite podcast app, or you can also listen to the recording and access the handouts on the AHC website at ahcc.decisionhealth.com. And if you have any suggestions for future guests or ideas about the format of this show, please send me an email at jan.milliman@decisionhealth.com. Thanks again, and we'll see you all next month. Take care.
Thank you, everyone.
Thanks.